Good evening and welcome. My name is Karen Marcinkiw. I'm Program Manager with the Alzheimer Society of Saskatchewan, and it's my pleasure to welcome you to our evening of education, Caring for Persons Living with Dementia, How to Support Responsive Behaviors, featuring our guest presenter, Dr. Tracy Danylyshen-Laycock. We also want to recognize that today is World Alzheimer's Day. Okay, and before we get started, we'll just get the slides on our screen here. Perfect. So next slide, please, Carly. Great. We want to thank you to our presenting sponsor, SGI. We're proudly supported by SaskTel Telcare. And before we begin, I just want to take care of a few housekeeping items. The presentation tonight will be recorded. Please know, though, that only the presenters are being shown on the camera, not you as participants, and your faces and names will not be shown on the screen. You have already received a copy of this presentation tonight. It was attached to your email with a Zoom link, but other relevant resources will be sent out in a follow-up email after tonight. The presentation will be followed by a question period. And during the presentation for the question part of things, you can type your questions in the Q&A section. So just click on that Q&A button near the bottom of your screen if you have a question that's relevant to the presentation. We will have moderators who will read them and summarize them, and then I'll be saying the questions to Tracy after the presentation. We would ask, again, that you keep your questions relevant to the topic being presented tonight. And if you have other questions, don't hesitate to reach out to our society staff at our resource centers across the province or by calling the Dementia Helpline. So now I'd like to introduce our guest speaker, and then she can get started. So I just want to read her biography. Dr. Tracy Danylyshen-Laycock has a Ph.D. in health sciences through the College of Medicine at the University of Saskatchewan. Her doctoral research focused on the relationship between leadership, facilitation, and the sustainability of a dementia-specific training program for staff in rural long-term care homes. Specifically, Tracy studied how the gentle persuasive approaches, the GPA, training program changed how staff provide care to residents with responsive behaviors as a result of a dementia diagnosis. She has an advanced honors degree in social work from the University of, she has an advanced honors degree in exercise physiology from the University of Saskatchewan, an undergraduate degree in social work from the University of Regina, and a master's degree in social work from Dalhousie University in Halifax, Nova Scotia. Wow, Tracy. Tracy is currently employed as the Director of Continuing Care for the 16 Saskatoon long-term care homes and the Transitional Care Unit at Saskatoon City Hospital. Tracy's married and has 2 sons who are involved in multiple sporting activities. She's passionate about providing care to individuals diagnosed with dementia and their caregivers. Tracy has been a GPA master coach through advanced gerontological education since 2010. She trains and educates staff across Canada in providing person-centered care to individuals with dementia. Her current research focuses on assessing and managing pain in persons with dementia. Welcome, Tracy.
Thank you for having me, Karen. Okay, if we can move to the next slide. So this presentation over the next hour and a little bit will cover the following topics. We're going to look at what a responsive behavior is and how they manifest as a result of dementia diagnosis. We're going to talk about the potential triggers to these responsive behaviors and the 4 areas in which we can look as caregivers to see what is actually causing the behavior. And then we'll look at some caregiver strategies in minimizing responsive behaviors. If you have questions, I'll take them at the end, and we can hopefully work through some of the questions that you may have as caregivers tonight. So as dementia progresses, we will see a change in the reasoning and language skills. They are gradually lost as dementia progresses. We will see communication become more behavioral. It is our goal as caregivers to try and understand what the behavior is telling us about that particular person's feelings or needs. The behaviors are a way for a person living with dementia to communicate with the people living around them. As the dementia progresses, reasoning and language skills are gradually lost. There's a declining ability to concentrate. They have difficulty organizing thoughts or following logic, problems understanding and expressing spoken and written language. We will also see that behavior is a means of communication, and this is something that you'll hear me refer to quite a bit tonight, is that we need to look at it as not just the behavior, but actually as a way for a person with dementia who has an unmet need, that there's something wrong within their environment or within their soul, or something happening for them that we need to try and figure out how to minimize the behavior. It's our goal to act as the behaviors behind. Our goal is to act as detectives behind the behavior to try and figure out what is actually happening and how we can help. Please remember that if you leave with anything tonight from this presentation, it's the term behavior is a key communication technique for people with dementia. Next slide. So what exactly is a responsive behavior? This is a term that has been used quite a bit in the research in people living with dementia. Responsive behavior is a term that represents how a person with dementia, how their actions, their words, and their gestures express something important about their personal, social, or physical environment. These are a result of the brain changing, which affects their memory, their judgment, their orientation, their mood, and behavior. And just remember that depending on the area of the brain that is impaired, you will see different types of behavior exhibited from different types of dementia and or different areas of the brain not working in the same way that mine and yours would potentially be working. So we will see different types of behaviors for different types of dementia. Next slide. So what exactly is a responsive behavior? So as I mentioned earlier, a behavior with meaning. So it's a response to something negative, frustrating, or confusing in their environment. It may also be a response to something external, a response to a feeling, or an unmet need. We call this behavior responsive because it is behavior with meaning. It is in response to a feeling or an unmet need, and we must understand that a person is responding to something negative, frustrating, or confusing. We need to try and figure out what those triggers are, either within the individual, which is sometimes a little bit harder than trying to figure out the external world. The problems in social or physical environment can be addressed or changed. It's just a matter of trying to figure out what those triggers actually are. There is some information within the Alzheimer's Society of Canada that you can take a look at through the Alzheimer's website, called Conversations About Dementia and Responsive Behaviors, and Shifting Focus, a Guide to Understanding Dementia and Behaviors. So if this is information that people are looking for, we can have the staff send that out to you. Next slide. So there are a lot of triggers behind responsive behaviors. So if you see the person within this diagram, the person living with dementia, you can see that there's numerous triggers behind the behavior. And sometimes it feels overwhelming as a caregiver to try and figure that out. But once we've sat down and maybe done some behavior mapping or just thinking, we, for the most part, can identify what the behavior actually is. So for example, it might be an unmet need, which I had mentioned earlier. So things like thirst, hunger, or toilet, those are sometimes easier to try and figure out. Sometimes a person is overstimulated or understimulated. They have loss of insight, so they have behaviors as a result of this particular impairment in their brain. They may choose to do things that we probably wouldn't have done prior to their dementia diagnosis. Medications can cause change in behavior and or responsive behavior. Sleep deprivation. This is an area that sometimes we kind of forget about. And so just a tip or something to recognize is that a person with dementia still requires about 8 hours of sleep, but their actual sleep circadian rhythms change. So they may actually be only getting sleep within a couple of hours at a time. So if they nap in the morning, they nap in the afternoon for a couple hours, you already have 4 hours of sleep. So don't be surprised if you do have a person living with dementia that maybe they're only sleeping 4 hours a night. So it's trying to get that sleep schedule going, or trying figuring out kind of what the issue is behind the sleep deprivation. Boredom can lead to responsive behaviors. Complex personal and life history or trauma. This is something that we see as people change and their own personal stories that have impacted their particular behavior. So for example, a person with dementia may have a fear of water if they've witnessed someone drown, or if they've had an accident, around water. So those are just some of the things to sometimes ask family members about, or recognize that those things that we may not think are an issue actually are an issue for that particular person. They'll have reduced communication abilities, which causes a lot of frustration and potentially aggressive behavior. Pain in people with dementia is often under managed and underreported, and this actually leads to a lot of behaviors. So my role for the last 20 years has been in long-term care. So when I was the behavioral consultant, I would get referrals from the different long-term care homes. And a good chunk of my behaviors and or the referrals that I receive were as a result of unmet pain management. So this is something just to kind of keep your eye out on. Psychosis can cause issues. If a person is living in long-term care, so care-related staff issues may also be a reduction, or increased behaviors, and we'll talk about that a little bit later in the presentation. A loss of independence, especially if we're in a hurry and we're trying to get that person out the door. We sometimes, do a lot of the tasks for them, and it becomes frustrated because they've been independent their whole entire lives. So even that can sometimes cause behaviors. Again, that's hand in hand with loss of control. Physical decline, depression and anxiety. We'll also see, a person isolating themselves or being more weepy. Those are some things to take a look at, especially if they've had a lifelong history. And sensory loss, if you look at vision and hearing. And that was one of the things that I figured out working in long-term care, is sometimes our family member or friend living in long-term care hasn't had their eyes checked, or hasn't had their hearing aid batteries changed. Those type of things in of themselves can cause behaviors. And at the very top, we have delirium. And so delirium, just quickly, is a sudden change in baseline behavior of that particular person that you're caring for. So if that person has been pretty docile, a quiet person, and then suddenly within about 24 to 48 hours, they're hitting, they're punching, they're swearing, potentially could mean that there's a delirium. And a delirium is anything physiological going on in the body that potentially can be causing a change in behaviors. So urinary tract infections, medications, sometimes COVID causes a delirium. There's a lot of different things, but about delirium, the difference that it is between dementia is that a delirium can be treated, where depression and delirium, can be treated, but dementia, it's not something that we can change. It's a progressive disease, where delirium, if we can figure out what the underlying physiological reason actually is, we can provide a solution for that particular behavior and for that person. So typically what I see in long-term care is a urinary tract infection that's gone undiagnosed, and it just needs to be treated with antibiotics. So just something to take a look at. Just recognize as caregivers that if it's a huge change in behavior, 24 to 48 hours, potentially there's something physiologically going on in the body. Next slide. So what exactly are some of the responsive behaviors? So when I hear people say, well, this person is aggressive, or this person is anxious, those are actually feelings. When you take a look at what the responsive behaviors actually are in the literature, you can divide them out into behavioral type of responsive behaviors or psychological responsive behaviors. So under behavioral, you'll see things like agitation, which usually presents as, banging on a table or pacing, picking at things, yelling, those types of things. Aggression can be looked at hitting, kicking, scratching, pinching, anything physical, or some of the verbal aggression that comes behind, swearing at staff, calling them names, screaming at the caregivers, that verbal type of aggression. Screaming and cursing, frequent repetition. So you may hear your loved ones say, or your friends say, "Where's my mom? Where's my mom? I want to go home. Where am I?" And those questions, to them, it's actually very, I use this particular example quite regularly when I'm teaching this course is, I had at one time, I have two sons, as I mentioned earlier, and I had one in Walmart with my mom, and he took off and I wasn't paying attention, and I turned around and I looked and he was gone. I don't know how many of you have actually lost a child in a store, but that actual alarm and the fear that goes through your mind when you can't find that person. Well, when you have advanced dementia, that's what's actually happening for some of our residents and or caregivers, or sorry, not caregivers, but people that we're caring for, is that alarm. They don't know where their mom is. They don't recognize that their mom has passed away, and they're trying to find somebody or something familiar to them. And so you'll see a lot of those type of behaviors. Wandering, sexual disinhibition, hoarding, urination or defecation, smearing is something that I've actually seen as well too, of feces on walls. It's not an uncommon behavior that you may see. And requests for help or repetitive questioning. Again, that's that hypervigilance and not recognizing or not seeing anything that they see as familiar in their environment. If you look at the psychological behaviors, you'll see personality change. So the person may have been very docile and complacent, where if they've had behavioral changes in sometimes their frontal or their temporal lobes, you may see things like aggression, swearing, saying things that they never would have said prior to their diagnosis. You may see some anxiety, some depression. You'll see some crying. A lot of people that have had a stroke have had tears that they're trying to control, but they can't. So you'll see some of that crying and you're trying to stop it and they're struggling. You'll see hallucinations. And the important thing to recognize is what is a hallucination versus what is an actual misinterpretation of the environment around them. So a hallucination is actually seeing, hearing, or experiencing touch of something that isn't there. And a lot of people that have had mental health issues have had hallucinations, but sometimes people with dementia who have never had a history of hallucinations, and I'm not saying that this won't happen or may not happen in some types of dementia, but they can't see very well. The lights are low. They may be misinterpreting a pole lamp for a person or a pillow on a bed as somebody in their room. And then they're telling you, I can't go in there, there's someone in my room. And then we're thinking, oh my goodness, they're seeing things. And we, tell the doctor that, my spouse is having hallucinations, when realistically, it could very well be misinterpretation of the environment around them. So just kind of noting the difference there. Delusions are actual thought processes that aren't particularly there. So they may think that somebody's out to get them, or they may say to you, somebody stole my wallet, somebody's out to get me, somebody stole my wallet. Again, is it a delusion, or is it the fact that they've lost their memory and they can't remember where they've put their keys or their wallet, and they're trying to come up with a plausible explanation as to where their keys or their wallet may have gone? Well, I think my parents might be on this particular presentation tonight. And for those of you that know me, I lose keys and wallets very regularly. So chances are this is going to be a thing that is going to happen to me. So recognize, is it truly missing or is it a delusion? So we need to kind of just do a little teasing out of what is actually happening for that particular person. Apathy is something that we see regularly in people with different types of dementia. So you may see that person, I see in long-term care where these particular people with apathy tend to be the most quiet individuals who really don't take a whole lot of staff time, because they're happy to just to be in, or they're in their room and they're not calling for anything. Apathy actually means that that person isn't able to initiate involvement in something going on around them. So they may not know that there's bingo going on, or there's something exciting happening on television, and they can't they can't begin to initiate the series of events that need to happen to actually bring them out to that particular environment. These people with apathy will sometimes be confused with depression. The difference that I typically tell people is depression, people know that there's things going on around them, but they can't bring themselves to actually do it because of the heaviness or the sadness around them. Where the apathy is, they don't know that there's things going on around them. And it's up to us as caregivers or staff to be able to spend time with that particular person, bring them out to the dining room or to the lounge or to wherever, to involve them, because these are actually the individuals who have the lowest quality of life, because people think that there's nothing wrong, that they don't need anything. And so we tend to not spend as much time as people with apathy. So again, just kind of knowing the difference between apathy and depression. And then you'll see an elevated mood or irritability. So sometimes depression and irritability go hand in hand with each other, but this irritability can be, they may have a, more of a hair trigger temper. They may be more irritated with, the sounds or voices than they were, years in the past. So these are just some of the particular responsive behaviors that we may see. In terms of those ones that have a star beside them, these are the things that can't be medicated. So screaming, cursing, frequent repetition, wandering, urinating and defecation and hoarding. These are, some very troubling behaviors, and they're often the most difficult to help minimize. And unfortunately, these can't be medicated. So, and for all of these, I always suggest non-pharmacological interventions first, and that's what we'll talk about a little bit later in the presentation, but just recognize that these particular things cannot be medicated. Next slide. So what are some of the responsive behaviors? So when you're at home and you are thinking about this, just because we're in Zoom, if we were in person, I would, sorry, I'm just getting a chat here. I would say to you, so what are some of the behaviors that we actually see? If you have the opportunity, write them down. But what you'll see is that behaviors can be physically or emotionally difficult. What may be a problem for you may not be a bother for someone else. A certain behavior may be constant for a while. So for example, repetition of questions. But generally behaviors change as the person's condition progressive. So we may be dealing with something for 6 weeks and we may not see that behavior ever again. So just recognize that although it seems like it's very difficult and frustrating, the behavior likely is going to change, or it's going to go away and something else is going to happen. Your family member will have good days and bad days, just as you have good days and bad days. However, his or her behavior may seem intense or out of proportion to how the situation appears to you. I would love to have a whiteboard or something in front of me that I could draw this out. But when you look at behaviors, if you can think of a triangle, and behaviors, thoughts, and emotions are all related to each other. So if you look at the affect, or it's actually called the ABC triangle. So the A is for the affect, and it's at the top of the triangle. B is behavior on the bottom right of the triangle, and C is your cognition. And so if it was us who did not have any changes in our brain or didn't have dementia, the ABC triangle would work like this. So if my husband showed up at work and brought me flowers, my affect or my feelings would be love, affection, appreciation. My cognition would be my thoughts. So my thoughts would be, wow, he must really love me. He was thinking about me. How did he know that I was having a bad day? My behavior likely would be, to hug him or shake his hand or kiss him on the cheek and thank him profusely for thinking about me. So how we think and how we feel will influence our behavior. But people with dementia, what's actually happening is that their ability to think through a situation is impaired. So their cognition is out of whack, or it doesn't relate in the same way as ours would be. So an example would be, if there were two residents side by side in a dining room and one resident hit the other because they took their cake or took something off of their plate, their affect would be, she took my cake. The thoughts would be, I'm so angry. This is horrible. They're out to get me. And then their behavior would be potentially hitting back or kicking or screaming or yelling because somebody took something off their plate. What's happening is that their thoughts are influencing their behavior in a way that if we were not cognitively impaired, it would not quite be the same thing. I would never hit somebody for taking something off my plate, but in long-term care or in people with dementia, it's something that we may see. So remember that these behaviors are disease-based, caused by damage in the brain. So behaviors are the person with dementia's form of communication. Next slide. So Mary has started to refuse getting dressed in the morning and insists on keeping her pajamas on. The first question to ask ourselves is, who is this behavior a problem for? So for example, is it a problem if your family member refuses to get dressed in the morning and insists on staying in their pajamas? I know that I have family members, and I won't point them out or name their names, who particularly like to enjoy their pajamas and stay in those for a good chunk of the day. For me, it's not a problem because I've seen that family member doing that for their entire life. But if it was me, myself, and I was in pajamas and my loved one was trying to tell me that I needed to get dressed, I may resist. I may not want to get dressed because it wasn't something that I did. I myself like being dressed with my hair and my makeup on. I probably will feel a little bit grumpy and will likely be in the bathroom trying to, fix myself up. So remember, is it a problem for me or is it a problem for the person with dementia? Who is the problem for? Behaviors are a concern when the person with dementia or others are at risk of being injured, or if the behavior is significantly upsetting to you or your family member. So for example, if there are safety concerns, consider the following. Approach your family physician for assistance, contact your Alzheimer's Society for support, and respite for the person with dementia to give the family a break for providing full-time care. Sometimes we can change the person's response to a situation by understanding the cause for his or her behavior and making necessary adjustments. This will benefit both the person with dementia and his or her caregiver. So for instance, a person with dementia may enjoy going for walks in a shopping mall, but may find a crowded mall confusing. In this case, it may be better to walk in the mall earlier in the day when it is less crowded. And are we hurting anyone if our loved one stays in pajamas until noon? Likely not. If you're going to get hit or sworn at, is it really risking hurting yourself? So the question is, who is the behavior a problem for? Next slide. So do you remember a time when you were afraid? Think about what your feelings were at that time and how did you respond? The reason for our response can usually be found in 4 areas: the person, the environment, the task, or the approach. Our goal is to try and prevent responsive behaviors or to minimize them if we can. Try to identify the triggers in any of these 4 areas and modify. Although it sounds easier than it is a difficult thing to do. So what exactly are triggers? You'll hear this word in the literature and some of the information that you'll see out on the internet. So a trigger is actually anything as an act or an event that serves as a stimulus and initiates or starts a reaction or a series of reactions. So it's basically that thing that we spoke about earlier, like being hot, cold. Some people don't like tags, some people don't like seams, other people don't like loud noises. Those are triggers that cause behaviors. So if possible, remove the triggers. So you may see sometimes a resident or your family member or the person that you're caring for, your spouse, may have a difficult time when they pass a mirror in the bedroom. They may say, "Who is that person looking back at you? Who is that old person?" Or they may be really upset because it actually looks like their mom. They feel or they think that it's, 1946 and they're 25 years old. They don't recognize that person in the mirror. So instead, what we can do is cover the mirror or take the mirrors down. Just some of the smaller things sometimes actually decrease the behaviors. So covering the mirror with a towel might be one way to go, or with a cloth, or just taking them down. If it is not possible to remove the trigger, try to modify or limit exposure to what is upsetting the person with dementia. So bathing, for example, is often very difficult for staff and for family members. Can we change the focus to person-centered rather than task-focused? So for example, is the person afraid of falling? Can they judge the depth of the water? So earlier in the presentation, I referenced change in vision for people with dementia. So what actually happens is that they struggle to discern colors that are very, very similar to each other. So if you have a white floor with a white or a gray wall, they may not know where the floor ends and the wall starts. It may be very difficult for them. They also have a really difficult time judging distance. So again, I'm coming from the lens of long-term care. Sometimes when a person is in a lift above a tub and they're going down into the tub, they may not recognize that there's water in the tub. They may not realize how deep it is. And they also really struggle with temperature. So it could be very, very cold to them or very, very warm. So some of the things that you may see help in the bathtub, for example, is, sometimes I think you can get dye for the water that doesn't color the skin. So at least the person can see the water when they're getting into the particular bathtub. The other thing to take a look at is, does bath time follow his or her usual routine? So for example, if somebody worked, in a mine or worked up north in a camp, maybe they didn't shower until after their shift at 8 o'clock at night. Is what we're doing in line with what their personal routine actually was? Did they normally take a shower or a bath? Was it morning or the evening? And again, is the temperature in the room too warm? Is there privacy? The thing to remember is, especially in long-term care, is a lot of our residents have never been seen without clothes on by anybody else other than their spouse. So when you go into a room and there's two caregivers who they don't recognize and they're not wearing clothes and they're in the tub, it potentially triggers behaviors. It's very embarrassing, or they don't recognize what's happening. It can also trigger trauma. Can we try things? And this is what I've suggested over the years is, for whatever reason, we struggle in long-term care, and I don't know if this is happening at home or not, but that they have to be totally without clothing on in the tub. And I'll say, but if it's causing behaviors and staff are getting hit and hurt, why can't we just leave a shirt on? Yeah, it's going to get wet, but they're easy to dry. So just using a towel over the shoulders. Amazon is amazing. You can actually order a bathrobe that is kind of like wrapping a towel around you. Can they have that on while you're, washing the bottom half, and then putting a towel over their shoulders while you're washing the top half? Like, these are just some of the things that we can think of to try and minimize the behaviors. Wet clothes can be dried, but if a person gets hurt, that's a harder thing to bounce back from. The other thing that people with dementia are very, very good at, and this is, again, the change in the brain, is that they get more information from your physical stance and your outward appearance and the tone and the pace of your voice than they do from what you actually say to them. So if you're in a hurry, if you're frustrated, if you're angry, they are actually going to sense that quicker than what you're actually saying to them. So what is our body and our behavior portraying to that person? And I always call it the mirror effect. What we mirror to that person living with dementia is exactly what we're going to get back. So the more anxious, frustrated, angry that we get, the more anxious, frustrated, and angry they're going to get back, that we're going to get back. So the thing to remember here is, if you insist, they will resist. Again, sometimes just taking that 5 seconds of a breather, recognizing what's actually happening inside of us, taking a deep breath. How fast am I talking? Do I have a closed body position? Just looking at those kinds of things can also decrease behaviors. So for example, one caregiver said the only way her husband would bath was if she would join him in the tub. And that may not be for everyone, but be creative. Sometimes, and this is a bit of a cliche term, thinking outside of the box is something that we need to do. We may not have done it before like that, but because dementia is something that we've never experienced before, we need to look at alternative strategies to help manage these behaviors. So responsive behaviors as a result of an unmet need or reaction to the environmental stimulus are some things that we're able to manage. If we can identify the need, we may also be able to decrease the behavior. Remember that persons living with dementia are not able to understand the environment in the same way as we do. People living with dementia are reacting to a stimulus around them, and they display different actions and reactions because they are experiencing dementia. As I mentioned earlier, our job is to act as detectives. We look for clues to try to determine what the behavior means and what the person with dementia is trying to tell us. Look for the reason behind the behavior, as this will help in getting you through the moment. One of the things that actually is really helpful to do is to behavior map. And it's just as simple as to try and track the times when that particular behavior is actually happening. And there's something on the internet called the Dementia Observation System. And it's just basically a table with every half an hour listed in a grid for 7 days. And you just highlight whatever behavior or whatever time that behavior is happening. And then you can actually track them over a 7-day cycle to see when exactly are those behaviors happening and how long they're happening for. And oftentimes, if we can figure out the time, we can intervene before it actually happens. In long-term care, you'll see a lot of the behaviors occurring as around staff change or shift change. What is actually going on is that there's so many people leaving, there's so many people coming in, people are grabbing their purses and their keys and their coats, and they're leaving. But the person with dementia can't understand why they can't leave. And so as soon as they see 3 or 4 people heading towards the front door, it's going to trigger them to actually leave. So if we know that there are residents or people that we're providing care for that tend to want to exit seek around the time when somebody, staff are trying to leave, can we, well, especially if your loved one is in long-term care, can we have our visits around that particular time around 3:30 when the shift are changing? Like just some of those simpler things to try and minimize those behaviors. So just remember that our goal is to minimize the behaviors. Sometimes we can get rid of them altogether, but for the most part, it is to minimize the behaviors. So expecting to get rid of them all at once with one intervention is going to be difficult. As caregivers, we actually have to have a plan A, B, C, D, and sometimes E. And although it feels frustrating, unfortunately, it is the reality with being caregivers or staff working in long-term care that it often actually needs several things to help minimize the behaviors. And sometimes what worked yesterday may not work again tomorrow. So it's a matter of trial and error and seeing what works and being able to be flexible about it. So as caregivers, we need to look for areas for triggers in the following areas: the person, the environment, the task, or the approach. So for example, next slide. So when we look at the person, is there something physical or emotional that is causing the behavior? So for physical causes, an example may be, if one day your family member becomes agitated, they complain of a sore back, they seem more confused than usual and pace all the time searching for the bathroom. This could be a delirium caused by an undiagnosed bladder infection. Other physical causes could be feeling hot or cold, thirsty or hungry. They could have a chronic illness. They may have some undiagnosed pain. They may be sleepy or they may be overtired. The changes in the behavior may be due to all of those things, in addition to medication, illness or fever, the day's activity or visitors. I know that, there are some people like myself that are very extroverted and like to have people around, but for that person with dementia, they may not be able to handle a 5-hour visit or several visits during the day from 3 different people. They may be just overstimulated, and you may see more agitation, more hollering, maybe some fatigue as well too. So just recognize sort of what their energy levels are. So examples that we can do to help manage these behaviors are some of the obvious things. So hearing aids, is the battery dead? Isolation is very real for people that are hearing impaired. And the more isolated they become, there's depression, there's behaviors. So if we can change the hearing aid battery on a regular basis, this will improve that person's quality of life. So for example, glasses, do they need to be cleaned or the prescription updated? And again, it may change very, very quickly for that particular person, but just recognize that these things actually do happen and they maybe have to be reviewed. Is the person wearing his or her dentures? What does their inside of their mouth look like? There could be sores. Their dentures could not be fitting, especially if they've lost a lot of weight. There could be some sores, or they're just not able to speak properly. And then because of that, they can't get their message across and they become frustrated. In terms of oral care, what does that look like? Do they have a toothache? Is there gingivitis? And is there a cavity? Emotional causes of the behavior might be fear or anger, anxiety, confusion, depression, or feeling stigmatized. Consider the person's social history. The man who gets up every morning at 4 a.m. thinking he needs to get up to milk the cows, as he did for years when he lived on the farm. The long-term memory stays intact longer than the short-term memory. So people with Alzheimer's disease or some damage to their hippocampus may have short-term memory loss. So they may not remember what actually happened yesterday or 5 minutes ago, but they have great recall for something that happened in 1956. And just remember that the deeper an emotion is attached to an event, the more likely that person is going to remember that particular event than they will if there's no emotion attached to it. So, my grandparents and my mom making pies or cinnamon buns, I love that smell. So if I'm living in long-term care and I smell cinnamon buns or baking, I'm likely going to be happy because it brings me back to when I was a child. Or if somebody is, traumatized, this may be not a thing as much anymore, but World War II survivors, when they hear overhead pages, or if they hear a fire alarm going, this actually traumatizes them to think that they're back in World War II and they have to protect themselves, or they visualize or believe that they're back in World War II settings. So just again, remember some of those things that will trigger a behavior are things that have a huge emotional attachment to it, whether it be a positive or a negative event or an emotion, either way. Next slide. Next slide. So the environment. This really looks at the person's environmental stimulation. So is there too much going on or too little going on? So caregivers continually strive to find the correct balance for the person with dementia. Enough stimulation to encourage participation in activities, but not too much stimulation that the person becomes agitated or has difficulty coping. This balance may change from day to day or may depend on the time of day. Environmental factors can be a trigger for responsive behaviors. So if we look at too much stimulation and break that down, too much stimulation and your family members may become anxious or agitated. They may pace, they may exhibit repetitive movements or call out. There might be too much noise, lighting, people, or colors. Rooms may need to be downsized if too many articles. Wall hangings, furniture, books, or magazines may be too much for them. There's just too much to take in and it's overwhelming. People with dementia are unique, and each person may respond differently to the environmental stimuli. They cannot selectively attend and filter out environmental noise, and their brain is trying to understand and respond to multiple stimuli. And the best way that I have thought about over the years to try and, explain what is happening for a person with dementia is, back in the day before Sirius XM and Apple CarPlay, when we actually had dial-in radios in cars, if you went in between stations and you heard static, you could hear a little bit of, one station and a little bit of the other station, and you've got some static. That's what's happening with a person with dementia. They're picking up a little noise from this person over here. They're picking up a little bit of noise from this person over here, but it's really static. And chances are none of us can listen to that for very long. And so that's sort of what's happening for people with dementia when there's just too much going on. And the same thing happens if they're living in an environment where someone is caring for them and there's one person talking over here and one person talking over here. They can't attend to both voices and interactions and watching the physical environment around them. It's just too much. And so what I'm teaching, especially the GPA course for staff in long-term care, I'll say 2 hands, 1 voice, if it's just a single caregiver, or 4 hands, 1 voice, if there's 2 caregivers. It should only ever be 1 person doing the talking if that person becomes overstimulated too quickly, and they can only focus in on 1 person at a time. So if there's anybody here working from long-term care, or if you have loved ones that are living in a long-term care home, If there's just one person talking, it helps decrease their agitation and their overstimulation. And it helps them pay attention. So staff members should be alerted to the fact that if there's 2 people or 3 people going in, it should only ever be one person and the same person talking if they can. So when you look at too little stimulation, your family member may withdraw or sleep much of the time. The person with dementia may try to create their own stimulation. So for example, they may be pacing, looking for something to do, starting to have repetitive motions. So sometimes you'll see it manifest in individuals if they have a sweater on and it's pilled, it's an old sweater, they'll start pulling at the pills on the sweater. Or if they're understimulated, they may start to tear Kleenex, or they may start to take clothing apart. A lot of different behaviors can happen because that person doesn't have enough to do. So when you see some things like those types of behaviors, try to see if that person has enough stimulation in their environment, and you may actually witness the behavior decrease. They may be crying out, they may be suspicious, and they may be paranoid. They may not know where people went. They may really struggle with people in their environment if they've been understimulated and then suddenly everybody's there. So what's happening? Or where did everybody go? So just trying to keep into account. I recognize that it is a tough situation sometimes, but again, recognizing too much or too little stimulation is a particular problem. And I think I addressed this a little bit later in the presentation, but when you are looking at activities for somebody with dementia, we need to recognize that they need to be stage appropriate activities versus age appropriate activities. Something that my mother-in-law, who has a little bit of cognitive impairment, actually quite a bit of cognitive impairment, it may be very different than what she would have had prior to the cognitive impairment. So if a person has really late stage dementia, they may be only able to manage some very simple puzzles or simple activities. And sometimes when we present them and say, hey, here's a puzzle with 500 pieces, they're going to really struggle with that. They're not going to be able to manage all of that. And then you're actually going to see an increase in agitation. So again, is the activity that we're getting them to do, is it age appropriate or stage appropriate? Recognize that it needs to be staged for the dementia progression that they're in. Next slide. So the environment. Change in behavior can be triggered by limitations put on a person's access to a safe environment. The person with dementia's judgment is impaired due to dementia. They may lack judgment, which can affect safety. We need to maximize safety, but allow as much independence as possible. The caregiver must decide how much risk they are willing to take in order to allow independence. You may want to discuss this with other family members. So look at the big picture when you're considering a person with dementia's environment, their access to safe areas to walk and to participate safely in activities of their choice. Simple changes to the home can help your family member by reducing confusion and preserving his or her ability to function appropriately. So for example, posting signs that have a picture of a toilet with an arrow pointing to the bathroom. And again, I talked about vision a little bit earlier. The more simple the sign is, the easier it is for them to be able to actually understand what's happening. So a picture of a toilet bowl may be easier for that person to understand versus, Tracy, please go this way to the bathroom. I may not be able to read that. So the more simple it is for that particular person, especially if they're in later stages of dementia, the easier it is for them to be able to understand it. If they're in a wheelchair and we post the sign way above eye level, it's really not going to help us. So again, is it at their eye level so that they're able to see it? Leave handwritten notes around the house in large print so they're able to see if vision is an issue. Label cupboards and or dressers if possible, especially if they're in earlier stages, but they're still struggling with some of the memory and or the process orientation of a task. You'll need to adopt the changing needs of the person with dementia. Something that works today may not work in a month or 2 months. Something may work one day and not the next. So again, as I mentioned earlier, flexibility is important. So some of the things that you can look at is in the area of home safety. So for example, area rugs, are they a tripping hazard? Adequate lighting. The more light you have at certain times of the day may be helpful. A night light that comes on when the family member gets out of bed at night to go to the washroom is also important or is helpful. Disconnect the stove if you are worried about your family member burning things. Auto shut off appliances eliminate some of the risk as well. If you are worried about wandering or the person exit seeking, try locks in hard to reach places. So for example, the top of a door frame. This may become frustrating for the person with dementia and they may give up trying to get out the door. Place security latches on cupboards that contain toxic items. Home security systems can alert you to when somebody leaves the house or enters it. So those whisper doorbells are helpful in some instances. Deadbolts decrease the chance of wandering outside at night. A bell or a buzzer on the door will alert you when someone gets up. And I think that there's really cheap door sensors that you can actually get from Amazon or even Canadian Tire that when you walk through them, it'll chime and you'll know that that particular person is out of their bed or in the bathroom, just so it alerts the caregiver that they are up and moving around, especially at night. Dementia affects a person's depth perception, as I mentioned earlier. So using contrasting colors to mark steps on a stairway can assist the person in recognizing the change in height. Or if there's contrast, a flat surface can look like a change in depth. So sometimes you'll see in a long-term care home or in a hospital, floors that are really shiny, and you'll see people with dementia sort of staying to the side of that floor or the hallway, or they'll be hanging on to the rails in the hallway. For people with dementia who have depth perception or sight visual issues happening, that floor may actually look like water or it may look like ice, and they're afraid to walk down the hallway. So just some of those perceptual changes actually cause some of the behaviors. Or bright blue floors. In some instances, that person thinks it's water and they don't want to walk any further. So just recognizing that some of those issues that we as ourselves may not recognize, but that's how they're seeing the world around them. Dark colored welcome mats. So a dark colored mat on the floor may be perceived as a hole in the ground, and the person with dementia may be reluctant to enter the house. Do not wax floors, as a slippery surface is dangerous and it creates a glare. Contrasting rubber bath mats inside the bathtub allows the person to see the bottom of the bathtub. If a person with dementia is urinating in different places, make the toilet as visible as possible. Keep your washroom door open, use picture signs, remove waste baskets next to toilets to avoid confusion. And sometimes in long-term care, I'll get a referral for people that are defecating or urinating in corners or in plants or in waste baskets. If we look at the Saskatchewan population, 10 years ago, when I was, in the midst of being the behavioral consultant, we had a huge rural population in our long-term care homes that were farmers. And so, if you're out on the tractor and there's nowhere to go to the bathroom, you're going to go on a field. So what are they interpreting? What is the environment around them? And can we minimize some of those things? So can we remove the plant? Can we remove the waste baskets? Like, just some of those things can help. Mobility and assistive devices, obviously installed by someone who knows how to install them properly. So for example, do we have grab bars onto the wall, into the stud versus just in the drywall? Just ensure that the home devices that we are using are safe. Have we been assessed for grab bars? Can you use toilet seats? Can we use a commode in the bedroom versus in the bath, like going to the bathroom? Like, there's just some different things that we can try. There's tracking devices that you can get to put in a person's shoe or their wallet. I believe that there now is GPS fall bracelets that are available through some of security monitoring companies, that if a person actually falls and the GPS actually picks up the speed in which the person falls, will alert a home safety security company and the family, so that you'll know and the company knows that that person has fallen. So just some of those things that are out there now, with maybe 20 years ago they weren't there. So those are always an option. Next slide. So create a multi-step safety plan. Nobody ever intends on getting lost, but it happens to over 40% of the persons with dementia, either by foot or by vehicle. Wandering refers to a variety of behaviors that are commonly associated with dementia. Wandering may occur at any time of the day or night. People with dementia may have difficulty recognizing familiar places. They're not able to communicate or remember their own name or address. They may leave home, they may become confused, and they may get lost. This can be dangerous for the person with the disease and worrisome for the caregiver. So create a safety plan so the person with dementia can live in the community safely. Strategies include making a customized identification kit. So a laminated card in your wallet or their purse, ID labels and clothing, and engraved jewelry. Fill out identification kit. So this organizes vital information such as a name, personal info, medication info, what to do if a missing incident occurs, and more. You can carry an independence card in their wallet. So an independence card is a wallet card to help people with dementia when in public settings. The independence card can be carried with the person with dementia and then shown discreetly to tell people they need help without making an announcement of the diagnosis to everyone around you. This card is for them to hand to someone to explain their circumstances and get assistance. You can ask the Alzheimer Society for these as well. Consider a locating device. So an electronic locating devices include things like a GPS or Bluetooth. It can be for phones, watches, key tags, etc. These tools follow a person's movement and identify their location. There are a number of locating devices on the market, and the Alzheimer's Society is unable to confidently provide info on the pros and cons of the ever-changing market or endorse any one product. But on the locating devices website, there is a helpful list of choices put together by the University of Waterloo. There's also a checklist for finding the right device for you. So please refer to that if you do have, or if you are caring for an individual who exit seeks or is wandering, to help you out with that particular instance. The Alzheimer's Society strongly encourages people recently diagnosed with dementia and their family members to have safety discussions early as a part of planning for the future. Next slide. So the task. Responsive behaviors can be caused by tasks that we ask the person living with dementia to do. Too complicated? Are they too rushed? Are we too rushed? We might be asking them to do something they're unfamiliar with. We might be initiating this particular task at an inappropriate time, or the person with dementia might lack awareness or attention. Have we asked our family member to do something too complicated, and have we made them frustrated? Have we set them up to fail? If you look, especially with a person living with dementia in their later stages, this is just generalizing. Sometimes these individuals can only understand 3 to 5 words maximum in a statement. But if we're suddenly saying, Dad, get dressed, come on, we have to go, put your shoes on, we're late, we have to get to church. That's way too many things I've asked of my dad. So when you're asking a person to do something, please keep the words limited to a very short sentence. So Dad, put on your shoes. And give them anywhere between 30 seconds to a minute to comprehend that one task, especially if they have, or that one phrase, especially if they have advanced dementia. If you need to repeat it, repeat the exact same statement, because as soon as you switch it up, they're still trying to process the statement that you made, earlier, and now you've just confused them with more words and or different wording of the same task. So we need to just give them a little bit of time to be able to process what we have asked them, and then give them that time to be able to answer back so that they can not only process it, but actually respond to it. Try to initiate activities during the time of the day when that person with dementia is most alert. If the person with dementia has always had their bath in the evening before bed, try to continue this routine if possible. The person with dementia's awareness of what is happening around them has changed. They may no longer be able to interpret cues in the environment that help them understand what is happening and what is expected of them. So for example, aggression during bathing. Bathing, as I mentioned earlier, is a very intimate act. Think about how you feel if a stranger came up to you and started removing your clothing. What would you do? Just think about that. What would you do if this was happening? And again, recognize that some people have had trauma in their life. So the particular act of actually having a bath may re-traumatize them. Not everyone, but it's still something that may be triggering for them. So the person with dementia may not recognize the person helping them or even understand why this person is taking their clothes off. So again, as I mentioned earlier in the presentation, can we keep them covered up as much as we can during bathing? Or even when we're providing care into like peri-care, or we're trying to, clean up after incontinence or bowel movement, is there some way that we can, keep the sheet covered up but still be cleaning? Like there are some ways to be able to do some of this particular care. We just need to kind of think about it and plan it out ahead of time. Next slide, please. So responsive behaviors can be caused by the approach that we use. And I don't want to be blaming anybody. This is not what this presentation is about. It's about if we do have a behavior and what we've been doing isn't working, can we try something different? So responsive behaviors can be caused by the approach we use. The person with dementia is still able to appreciate, respond to, and experience feelings such as joy, anger, fear, love, and sadness. Think about how we communicate. Our approach can make things easier or more difficult. Be conscious, as I mentioned earlier, of your body language. I know I have a habit, and I know nobody can see me, and I wish we were all in person, of crossing my arms and having conversations with people. And especially if I'm, in a serious conversation with somebody, it really looks like I'm either being rude or I don't want to talk to that person. So if the person with dementia is picking up, I think research says around 90% approximately of the meaning about their world through tone, voice, and body language. This close stance is going to tell that person with dementia that I might be frustrated, angry, upset, when in reality, I'm not. So be conscious of our body language, our physical positioning, the tone of our voice, and our current mood or our emotions. When we are frustrated, they are frustrated. So it's okay to take a couple seconds pause. When we're teaching staff in long-term care, it's called the stop and go principle. Stop what you're doing, think about what our approach is, observe what is happening, step back, and you may need to step back and obviously not leaving a person in an unsafe situation for a couple of minutes just to regroup and then come up with a plan. If the person with dementia is sitting in a chair and we are standing above them looking down, speaking sternly and frowning, what kind of response might we get? If they just hear the volume and the tone but don't understand the words, that could be very frightening to them. So just recognizing that they get more information about their world through these things on the slide than they do what we are saying to them. So what we mirror is what we get back. Next slide, please. So caregiver approaches to care. So these are some of the things to try to stay calm. And I recognize that sometimes that's easier said than done. To view things from the person's perspective. So what is happening? Can we put ourselves in their shoes, knowing what we now know about the person's experience with dementia, living with dementia? Can we look for and build on that person's strengths? So what are they able to do? Are we able to involve them? They may not be able to get dressed, but could we give them two options? Would you like the red one, the red shirt, or the blue shirt? If you want somebody to do a task, you provide them with options and closed-ended questions. So the red one or the blue one. If you want to engage in a conversation and you want to reminisce and maybe potentially even redirect that person, you ask them open-ended experience questions. So things like, tell me about your mom. What kind of an amazing person was she? Or what did you and your mom like to do together? Tell me about her. That way, you're asking that person to provide you with an experience that they can speak to, if possible. But if they can't make choices, don't provide them with 10 different things. Limit those things to 1 or 2 options if you can. So task focus is closed-ended questions, yes or no, if you can. Redirection, connecting, open-ended questions, experience. Remember to practice the sense of humor. A lot of people respond to that. Practice good communication skills. One thing that I found out, and I will take the blame for this, is I talk really fast. And sometimes I will have a conversation with my back turned. And so if a person is wearing hearing aids and their glasses are not working, or their glasses are the wrong prescription, and I'm a staff member and I'm looking into their closet, talking to them and asking them what they want to wear, that person may not be able to even see what I'm doing, hear what I'm doing. So please ensure that they can hear you and see you. How am I portraying the message that I need to get to them? Try not to take comments and actions personally. It's the disease that's causing this, not the person. Try not to argue or reason. They can't enter our world. Their brain just doesn't allow them to. So we need to enter their world. And the best way that I can, provide you with some context around it is we would never ask somebody who had 2 broken legs to run a marathon. Why would we ask somebody with severe brain impairment as a result of dementia to do something that their brain no longer allows them to? We seem as a society to struggle with, if we can't see that the person is impaired in some way, shape, or form, whether it's dementia or mental health or in a brain injury, that if we can't see it, then we obviously assume or presume that they can do it, when that's not always the case. Remember, there are no magic solutions. However, we can make a positive difference if we follow these guidelines. Influencing behavior is a process of trial and error. Have plan A and plan B, and sometimes C, D, and E. Often the only way we can cope with the behavior is to change our reaction to it and to ask, does it really matter? My mom, if she's still on the presentation, will say to me, Tracy, does this behavior matter in 5 minutes, 5 weeks, 5 years, or 10 years down the line? Does it really matter? So just a question, if we are taking a couple of seconds to sort of check in with how we're doing, does this really matter right now? And try and keep your sense of humor. Know the disease, know the losses and retained abilities, and know the person. Next slide. So in living with somebody or caring with somebody who is displaying responsive behaviors, have the support of the others who understand can be helpful. The Alzheimer's Society of Saskatchewan offers support groups for people with dementia and caregivers that can improve quality of life and the ability to cope with the challenges of the disease. Saskatchewan dementia support groups are offered in a variety of formats. So for example, in person, virtually, hybrid. So sometimes a person can attend in person or virtually by Zoom and over the telephone. Alzheimer's support groups can offer a chance to exchange information and friendship with others living with and affected by dementia. Access the most current information, learn and share practical tips for coping with change, decrease feelings of loneliness and isolation, and finding a sense of hope. For information about the Alzheimer's Society groups throughout the province, please go to their website or contact their dementia helpline, which is listed on our slide. There's also a website that you can also find tons of information. Individuals with questions about getting a diagnosis may benefit by speaking with the Alzheimer's Society of Saskatchewan Diagnosis and Support Coordinator. The Alzheimer's Society has First Link coordinators who can provide you with one-on-one support to information, support services, and education. There are also learning opportunities like this evening, as well as a learning series. Courses are held to help people with dementia, their families and friends to live as well as possible with the disease. The courses offered build upon each other and cover the continuum of the disease. The evenings of education are held virtually by Zoom. Our standalone topics presented by content experts offered about 4 times a year. And again, the Dementia Helpline is available to answer your questions about dementia. So you can call 1-877-949-4141, Monday to Friday, 8:30 a.m. to 4:30 p.m. Central Standard Time. So it is now about 10 after 8, and I usually teach a course that lasts 8 hours on all of these different topics. This was only an hour and 10 minutes. But you know, I will be able to answer some questions at the end of this presentation. So in general and throughout this particular presentation, I hope that we were able to cover what a responsive behavior was and our role as detectives behind the behavior to see what we can find out those triggers. Triggers can happen for the person within that person, their environment, within their tasks, so what we're asking them to do, and the approach. Please recognize that there is support out there. You do not have to go at this alone. So please reach out to your Saskatchewan Alzheimer's Society to help